in 2021. So I actually just I'm still a new grad. This is my first year working for USC, and I am full-time there, and I will be basically giving you a bit of an overview as what it is to be an X-ray tech. I'll be giving you a bit of pointers when it comes to interviews, as well as things that you may need to succeed or that can help you succeed when it comes to, obtaining and keeping a job, basically. So we're going to go ahead and begin. So the presentation is called Gaining X-ray Vision, because little did I know that after I became an X-ray tech, it is kind of like you gained X-ray vision. But I will go ahead and guide you, and I'll tell you exactly how that happened, okay? Go ahead and switch the slide for me, please. Okay, so I'm going to begin by telling you a little bit about how X-ray started. So the father of X-ray, basically the person that invented or founded X-ray, is Wilhelm Röntgen. He discovered X-rays in 1895, and I believe the exact date was November 8th. Now, he was a German mechanical engineer as well as a physicist, and he ended up actually radiographing his wife. She was the first one who he ever shot an X-ray of, and that's actually her hand there in the picture. Now, X-rays are basically a form of ionizing radiation that are used to portray images of the body. So you get images, mostly of the bones, organs. It's a little bit harder to see because X-ray tends to overlap certain organs, so it doesn't give you as great of a view as CT would, but it's still good. Clarence Madison Daly, she was actually the first to die of an exposure. She was poisoned from so much radiation in 1904. Now, granted, back in the day, they did used to use X-rays even in like cocktail parties. They didn't exactly know the danger that it was causing, so they would just go around and say, hey, you want an X-ray? Go ahead. And eventually, she was the first to be poisoned from it. So I don't think they continued that in their cocktail parties after that, but hopefully they learned. If you may go ahead and change. Okay. So I'm going to go ahead and start with radiography, which is exactly that, X-rays, right? The images of bones and basically just the body. To me, it's always been very fascinating. I've always loved to see how the bones look on X-rays. I think the skull is always my favorite, right? But anyway, in radiography, you use basically, of course, you use radiation to get the images. Now, you have certain rooms in which you bring the patient in, you're able to take an X-ray of them, but you use certain devices. So there's a table that has what is called a bucky, and that's the picture that you'll see down there with the red circle around. That's the bucky. We have certain cassettes that go in, of course, and you're able to obtain the images through there. The X-ray tube on top connects with the cassette, and they basically communicate to get an image of the person's body. Depending on what part you're getting, whether it's thicker, it's smaller, you position, there are always certain ways to position a body, and it's not as easy as just always laying them down. Sometimes you got to kind of give them a little turn here and there, and it can get a little tricky. But it's not very hard as long as you basically know your anatomy. That's, I think, a very big portion of X-ray, is just knowing where that anatomy is. Okay, so the machine that you see in the middle, that is called a portable, right? It's a portable X-ray machine that we take up to the patient's room. It'd be a little inconvenient if you're constantly having to bring patients from the rooms down to our rooms, and not every patient is stable enough to really have X-rays or keep coming down and being bothered from their rooms down into bringing them all the way down to our rooms. And sometimes it can be a bumpy ride, so it's not always best to have them come down just for a simple chest x-ray, when that can be changed. And with this portable, right, you can actually go to them, take the machine to them and do the x-ray there in the comfort of their own room. And it can be a little tricky sometimes. You have to take into consideration so many things that I before would not even think about, right? You have a lot of IV poles. And let me tell you, you cannot touch a nurse's station, and their IV poles are like sacred. Okay, you don't mess with the wiring, you don't touch their IV poles, anything that's connected to the patient, you basically want to avoid touching. Unfortunately, sometimes it does make it hard and you kind of have to. So it's always good to have the nurse there with you, supervising you, making sure that you know, hey, am I okay to move them? Am I okay to lay the patient flat? Am I okay to sit the patient up more? As long as they give you the okay, I think you're good to go. It's always, it could be a little tricky, but you end up getting the image. It's a lot faster and it's more convenient for the patient. At the end of the day, I think the patients being more comfortable is very important, and having them feel safe around you is also a big portion when you're doing x-rays. You know, the more they feel like they can trust you, the easier it is for them to work with you. And if you may change the slide for me. Now, you obtain this image, right? Sometimes they'll ask you questions like, they'll tell you, they'll ask if it's broken, do you see anything wrong? And as much as you want to say yes, because you can see that nice snap, it is not okay to say yes, because at the end of the day, you're not exactly the doctor. As great as you get at reading these x-rays and knowing what you're looking at, knowing the pathology, it's against basically, how can I say it? It's out of scope of practice, consider it. You cannot tell them, yes, it is. Because the moment you say, yes, it is, for some reason, what if it wasn't? Maybe it was just dislocated, and now you gave improper information to this patient, you know, and for all you know, they're probably going through a whole panic attack, and now not only do they have a broken bone, but they're having this attack that you're trying to calm them down for now too, you know. So there's simple little things that you think might not make a big difference, but it really does. So definitely remember, no matter how broken it is, no matter what you know and what you see, don't say anything. The most you can say is the doctor will give you your results. My personal favorite I tend to go to is, you know, the doctor makes the big bucks. He will let you know what's wrong. If you have any questions, he can also elaborate. So it's a little way of me going around their question too, you know? Go ahead and change, please. Okay, so x-ray is it's not as simple as most people expect, where it's just x-rays. It's also fluoroscopy. So in this case, in fluoroscopy, it's basically a live video of x-rays. It gives the radiologists and doctors a chance to see how certain organs in your body are working, right? Now, for these, you have very different studies, right? You have studies such as upper GIs, right? The upper gastrointestinal tract. Now, for this one, you're basically giving a patient contrast. You're giving them a type of liquid and that they drink, and you're able to see how everything functions. It's very different for you, say you go ahead and you take a sip of water and you swallow it, you know, you don't think anything of it. But when you actually see it in an x-ray, there's so much going on just from that one sip of water. Now, even patients sometimes, when they get that slight little glance and they see their own images, when they're like, wow, really, that's how it looks, huh? And Granted, some of them tell me that they have no idea what they are looking at, which it's understandable, of course, because it's not like it's something that they were studying. But it's a very useful form of X-rays. You have procedures like video esophagograms, right? You have cystograms. A simple sniff test is where it's exactly that. A patient goes and inhales or basically sniffs, right? And all the radiologist is basically doing is observing the way that their diaphragm moves. There is so much that it can tell you, and that's what it looks at. It looks at abnormalities of the diaphragm. And I don't think that's something that everybody really considers thinking, is that even such a big issue? For us, it might not be, but at the end of the day, you never know what could be wrong, where a simple test like a sniff test can make such a big difference. You're able to see and diagnose like hiatal hernias with the upper GIs or esophagograms. You're able to see any ruptures after surgeries for cystograms. It does take a lot, but in this case, you're working directly with the radiologist to assist in any way that he needs. Working the machines for them if they have to, helping position the patient, recording the videos if he needs it, or even obtaining more contrast. Anything that they need, you're right there by their side to assist. So this one, the procedures aren't very invasive, which is good. But it does give you a chance to work directly with the radiologist. So if you have any questions about any of these procedures, that would be the best time to ask the radiologist, because majority of the time they do answer your questions. They do say, hey, like, what do you want to know? And you just ask them like, hey doc, can you run it through for me? What do you think of this? What is this area here? Any pathology you might see? Simple communication with your radiologist, it will help you learn a lot more for the next procedure, the next one that you do. Even asking them, what do you think I could have done differently? There are some radiologists that do take time out of their day and they will help you. They will guide you and tell you, okay, you know what, you could have done this a little better, or maybe go a little faster. Tips. It's a lot of constructive criticism that will help you be better prepared to assist this radiologist. Right? Everyone has their own way of doing things, so it is very hard for you to say, I'm going to memorize exactly how this radiologist likes his things. You have to take into consideration that every patient is different. That patient that you had yesterday that was able to, turn around and sit up and move so easily is not the same patient that you have today. Maybe someone completely different that isn't able to make that turn so easily. So you always have to learn to adapt. Things are not always going to be done in the same routine, but you have at least a bit of an idea of what he expects, you'll be able to still help them out really well. If you can go ahead and go on to the next. Okay, so one of my favorite things, I know it's not everyone's favorite, but one of my favorite things about X-ray and being a tech is I get to go to surgery. I get to see a lot of very different procedures that to me are just pretty fascinating. Now, don't get me wrong, the very first time I heard of surgery and thinking, oh my goodness, there's gonna be blood. How am I gonna react? I was really, really nervous, thinking at some point I might faint. I don't know, I've never been in this situation. So in reality, before I even got into the OR, I was already making myself so nervous and freaking out and thinking, how am I gonna do this? Of course, there was a tech with me. There was my CI was with me and said, you look really nervous. You need to calm down. And I said, oh my gosh, like I'm already almost sweating and I haven't gotten in. I took a deep breath. I went in and I was honestly just fascinated by everything in the OR. The amount of, like the fast pace that they had, the amount of communication everyone had, and how honestly they were willing to help me. And they knew I was a student, and I walked in, I grabbed the machine, they were guiding me. Everyone in that OR was guiding me. You know, the surgeon was telling me, okay, you see the green button, go ahead, green arrow up, green arrow down. It was an experience that I had that I think helped me, where I wasn't as afraid the next time I went in, and I knew that I wasn't going to be fainting from blood. I figured if I can handle this, I'll be okay. And the more I went into surgeries, the more I just thought, man, these people are just amazing. I mean, they are literally fixing a human being in front of them, and I get to assist, right? So you go in there and you have a C-arm, which is kind of like fluoroscopy, where it provides either images or it provides video for the surgeon. They are able to see exactly what they're doing with these images, whether it's inserting a nail or filling the bladder, because they also do cystos in surgery. They are able to see what they need, and you are there to basically be another set of eyes to them, right? Whether they tell you go down, go up, give me a nice little tilt of the image, or go ahead and rotate it, anything that you need, that the surgeon needs, you need to be educated on these machines to be able to do it, right? Sometimes they tell you, like, man, I can't see anything. This image is pitch black. Help me. You're like, okay, so we need more penetration. We need to play with the contrast. I need to do what I can to get a good image for this doctor, right? The O-arm is the machine that's on the top. For mine, it's the top left-hand side. I hope it's the same for everyone. That machine is amazing. It kind of reminds me of CT as well. It basically is a giant version of a C-arm. It is very hard to maneuver. And even though you're going down that hall with this giant machine, nobody sees you. Everyone still walks right in front of you. You're like, oh, and it's that sudden stop. But once you're in the OR of, you know, the surgeon that is requiring the O-arm, it's a completely different feel, where everyone is coordinating, everyone is looking. Are you, you know, to make sure that you are placing that machine exactly where it has to go. You are getting the image that is needed. There's always someone there that's going to help you and guide you. These images for the O-arm come out much better than the C-arm. I mean, they come out basically like a 3D image. And it was really amazing being able to see it. I've mostly only seen it and been able to use it for spine cases. I'm really hoping to get to use it for more. I believe we do one in a neuro case where it has to do with the brain, but I haven't been able to see one of those just yet. Anyway, these C-arms, they are very good to use, amazing, a little tricky to handle here and there, but once you get the hang of it, I think it's great. Honestly, with these, it's not a matter of you hearing how to use it. It's definitely more of a hands-on machine. You have to get practice with it in order for you to also get out of those nerves. You know, when you go in and you see everyone and they're waiting for you, just go in, do what you know, and just be confident with these. Anytime you go into a surgery, just remember, confidence is key. You know what you're doing. You have done it before. And if you haven't and it's your first time, do what you can, but don't shy from it. You have to get the practice, no matter what it is, no matter how scary, okay? If you may go ahead and go on to the next. Now, anatomy. In order to get your X-ray vision, anatomy is key. Okay, I cannot stress that enough. You definitely want to know every single part of the body, how it works, how it flows. You want to know because every patient is different, right? Every size is different. But there's one thing you always have to remember, that once you know your anatomy, right? Let's go ahead and go on with bones. Once you know where that hip is or the shoulder is or the femur, when you know where it's located and what it's connected to in the body, no matter how big or how small the patient is, that bone doesn't really move. That bone is going to be in the same location. So if you see the chest x-rays that I have there, the one on the left-hand side is from a thinner patient. The one from the right-hand side is a little bigger. So if you notice, the lungs are still in the same place. The only thing that has changed is soft tissue, right? There's a lot more soft tissue on the right-hand side, yes, but the lungs are still in the center. The heart is still there. The spine is still dead center in the middle. So the best way for you to learn and get your x-ray vision, for me, is definitely learn your anatomy. Okay, know where your bones are, little landmarks. Like say, okay, if you're looking for the pubic symphysis on a body, right? Your best landmark to find it without, because it's not a place that you ever want to touch. You don't want to palpate for that area ever. How are you able to know where it's at, where you will put, your cassette at for a pelvis if you can't palpate? On the sides of your hips and down a little lower towards your thighs, you are able to feel a bone, and that is the greater trochanter of the femur, right? That greater trochanter is always going to be at the level of your pubic symphysis, which is really, it's a great landmark also for KUBs, not just for the pelvis, right? Because for KUBs, you always want to include the bladder as well, and that pubic symphysis is a good stopping point for it. Now, you also want to get diaphragm, of course, but after you get that initial one, if you don't, you're always able to move it up higher, but you'll at least have an idea of where that pubic symphysis is. So your landmarks are very important when it comes to x-ray, okay? That the hand, your fingers, everything, you start to see the body in a very different way the more you shoot the x-rays. No matter the many different types of patients you have, those bones are exactly where you need them to be. Those landmarks won't change. Okay, don't get me wrong, there are times where you have very different patients, that have certain disabilities or their body is just very different. But again, find a landmark and go with it. Whether it's a xiphoid process that you're trying to find, it's that sternal notch, anything that you need to get you an image. The prominence of C7 is great when taking chest x-rays. If you have your cassette right there, basically the top of the cassette at the level of C7, you should be good almost every time for a chest x-ray. Okay, so landmarks, anatomy, it's very, very important. I do recommend it for you guys when it comes to shooting x-rays, if that's the path you want to take. And in order to get your x-ray vision, definitely learn your anatomy, okay? Go ahead and change the slide for me. Thank you. Now, one door does lead to many. X-ray can be maybe a starting point for many of you, or it's just maybe a passing door for you, right? Because it does lead to many. It's X-ray, you have radiography, you have mammography, you have computed tomography, so CT, MRI, interventional radiology. All of these things are all connected with radiography. Now, you have your MRI is one of the few that doesn't actually use radiation. But I won't be touching up too much on this, but I will give you at least an overview of what they all are. Now, in mammography, you're basically taking pictures of the breasts, of females' breasts, or even males, in order to check for breast cancer, okay? In computed tomography, it's basically you have x-rays that are being rotated around the patient to generate cross-sectional images. So you will have not just a simple AP view, but it's kind of like you're cutting the patient into slices, where you have a sagittal, coronal, and axial view, and it gives you way better detail of the organs. It's amazing to see as well. MRI is the use of a large magnet, right? And radio waves to create images of the body. It's almost similar to CT, where it also does the cross-sectional images, but it goes in much further detail. There is a very big difference, and on the image I have there at the top, you have the first picture is of an X-ray. The second one that looks a little bit more on the gray side is a CT, and the other two are MRI. You are able to see the intense detailed difference, right? Where some actually shows even muscle. The MRI goes into depth with bone, muscle, so many more things. If it's something that you are interested in, where you're willing to go to even further anatomy, I definitely recommend MRI. You have interventional radiology. That one is basically where the doctor uses imaging to guide with their procedures. You have drainages, you have blood clots in the veins or vessels, and you have bleeds or strokes, and you're basically using needles, catheters, wires, anything you need to try and assist these patients with certain conditions. It's a very, it's much smaller, invasive, it's a less invasive procedure that you do in there. And it is definitely a lot more life-changing for some people when they have these procedures done. Interventional radiology is, in my eyes, the most hands-on department that we have. And it's definitely one where you are able to change a person's life a lot more. I have seen a few procedures, not a lot, but I can tell you it's a lot of small detail that has to be taken into consideration, and it is it's really awesome to see, honestly. If you get the chance to, and if you're a student, and you're doing a rotation, I definitely recommend interventional radiology. Go ahead, take a look at it. You never know, you might end up coming out one day with a big old smile on your face thinking, that's what I want. That was actually out of experience, because when I first went in and they took me and I got to see a procedure, some of the techs that I was working with at the time were laughing because they go, man, what did they do to you? You came back so happy all of a sudden with this big smile. And I was like, yeah, I think I really want that. But now I'm like, there's so much more to radiology that I'm still undecided as to whether I want to continue and stay in X-ray, or I want to do something more. Currently I am in CT, so let's see where I go from there, but I am going to continue to broaden out my modalities as well. Now, let's continue. You have radiation therapy as well. That one, I believe it should be the picture, I think it's the second one on to the right side, closest to the letters that I have, where you see that green light on the patient. That one is for radiation therapy. It's basically cancer treatment. So you have this high dose of radiation given to this patient in order to kill cancer cells and shrink these tumors. So whenever they get diagnosed with these pathologies, that's basically where you want to go to. So if treating cancer is something that interests you, radiation therapy is really good. I'm not sure, I think I might have missed nuclear medicine, but let's see. Nuclear medicine is where you use small amounts of radioactive materials, or kind of radiopharmaceuticals, I think is what they're called. But it's meant to examine the organ function and structure of the body. Lastly, and I don't think a lot of people really know about this one, you have the opportunity to work in dosimetry. Dosimetry is basically the measurement of radiation exposure that you're going to be giving to a patient. So you're basically making a plan with the radiologist as to how much radiation you're going to be giving this patient. Not very many people know about it. It is definitely something to look into if you're interested. Okay. If you're able, go ahead and change the slide for me. Thank you. Now we're going to go ahead and go on into interviews. Yes, confidence is key. Now, when you go in and you're nervous, you're thinking of all these things in your head, strengths, weaknesses, what you're going to say, you know, what are they going to ask me? What should I do? Go in, take a breath, relax. Everything that you could do to prepare has already been done. So at this point, you can't be worried about what you should have done or what you should say. Because as much as you want to practice something, it is not going to come out the same way because you have no idea what they're going to ask of you, how the whole conversation is going to go. You know what you want to say, but you're not really sure what they're going to talk to you about just yet. You have an idea. Obviously, they want to know who you are, what you do, and what you are basically going to be bringing. In other words, bringing to the table, right? For me, when I had my interview at USC, I did do research beforehand. I wanted to get a bit of an overview of what USC stood for, what their goals were, what type of, exactly what they were looking for when it came to the position I was applying for, right? So what were the key, how can I tell you, what exactly they wanted in a person for this position. I researched as much as I can. I went back even to history as when the actual hospital started, right? I went a little bit too far back. They didn't really ask me any questions of that, but it doesn't hurt for you to know, for you to learn of the place that you're going to be trying to apply for a job for, right? Now, you have the knowledge. Once you're going in for a job interview, you know, you're going because you know exactly what you need to do for this job. You know that you can do it. So you go in, and for me, I basically tried to beat them at their own questions, where I was applying for this radiology position, right, as a rad tech. And they did ask me, you know, what are some of your strengths? And I was already at a bit of a disadvantage because USC was not one of my rotations for a class. Now, when I went in and they asked me, you know, what are your strengths? Well, I remember researching USC is very big on C-arms and surgeries. So what I focused on was telling them, you know, I had a lot of experience with surgery when I did my clinical rotation at City of Hope. I recall using the same portable machines that you guys use and some of the software you use. I'm actually very familiar with it as well, which will, you know, make my training a lot easier and faster. So it's simple little things like that, but everything connected. Both my research as well as my skills, I was able to bring to the table and say, this is what I know. These are my strengths, right? You're basically trying to sell yourself. Okay, you want to try and be, because you have so much competition out there. Remember, there's a lot of people that are going to be competing for this position. So what is going to make you stand out? And that research might be what helps you. Okay, you have the knowledge, you finished school, you know what you're doing. You have to go in, be confident, and ask questions. You know, when I started, I think when I was in my interview, I did ask, you know, what C-arms they had, because that was something I didn't get to see. What machines do you use? Is there anything else that you, other machines or any other things that you require from me that wasn't listed? And yeah, they were able to tell me that we were also going to be working with a faxitron, which is basically a machine in which you take x-rays of cancerous breast tissue, basically pathology tissue that to see, you know, I guess you're trying to find these clips, whatever they need in that in the pathology lab. You basically go and you work on this different machine for, and that was something I hadn't worked with. But it was something that I told them, okay, I'm looking forward to working with that. I can't wait. You know, you don't just say, oh, no, I've never worked with that. I can't, I'm sorry. You don't want to go and make yourself look like you're not willing to try something new. Because at the end of the day, it benefits you, because now you're able to apply that to your resume when you're applying to another job and say, hey, I also know how to use a faxitron. You know, so everything that you need for your interviews, you technically already have. You have the knowledge of from your school, you have your experience from your clinicals. You just simply need to apply and show them that you have it. Okay, you can go ahead on to the next one. Okay, and this is kind of a bit of a overview, a little bit of how to succeed. Okay, so once you get the job and you start working, you want to go ahead and be able to communicate with everyone around you, whether it's your supervisor, it's your fellow techs, it's people in the nurses, the surgeons. It is very important for you to communicate in this field. Building relationships is a very big factor as well, where if you know that, you know, these nurses, if they need a little bit of help, hey, can you help me turn the patient? Or can you help me, you know, position, or can you hand me something? You helping them, that little second of your time that you put into helping that nurse is always going to be helpful to you, because one day you may be struggling to push that cassette in or struggling to get your machine into the room. It's going to be a lot easier for them to say, here, let me help you. You know, it's establishing relationships with nurses, with the doctors. It does help. It goes a long way with you when you as a tech take interest in them and their day as well. You know, it's very important, I think, for you to adapt to change. Now, adapting to change is basically, okay, today you're going to be working in fluoroscopy, right? And you're used to doing things a certain way. But then when you get a new doctor, we're not following that protocol. You're going to follow mine now. You know, so things do change. Doesn't mean you're doing anything wrong. It just means you have to adapt. Now, if you remembered how a certain doctor likes it and this one does things very differently, all you're doing is just changing that little bit of a routine that you had in order to also make a relationship with this new doctor coming in, you know, to show I'm willing to do things the way you like it. You tell me what you need and I will get it for you. You know, you have to try and always think outside the box. It's something that will benefit you in the long run. Okay. As a tech, I definitely recommend for you to try your best to be very efficient, you know, have everything ready before you bring the patient in, go over the studies, do everything on your way coming into the room. You just want to have everything be a nice flow. Okay. That way, in the long run, you end up gaining a lot more speed and things go a lot faster. Remember to treat every patient like family. And I think that will definitely be a very big factor for you to succeed. Patients are family. They aren't just a job. Treat every patient like family, and I think you will be able to grow a lot more as a tech. Okay. Next slide, please. Any questions?
I had one. You were mentioning moving the O-arm through the hallways. So do you need to sanitize that when you bring it in, or since it doesn't touch the patient, do you not need to, or how does